continuation of my previous lecture in which we have learnt about the different types of heart failure, the causes and the signs and symptoms. So today I will explain the relationship between vascular tone and heart failure. So heart failure, as we all know, is a condition in which the heart can't pump enough blood to meet the body demands for blood and oxygen. Vascular tone is a key regulator of tissue perfusion. It determines whether the tissues will receive adequate or sufficient oxygen and nutrients. The vascular tone refers to the tone of the coronary blood vessels, the tone of the peripheral veins, and the tone of the systemic arteries. So we will see how the tone of the blood vessels, the resistance of the blood vessels is coupled to stroke volume, cardiac output, myocardial oxygen demand and heart failure. So to start, in my previous lectures we have learned that for adequate tissue perfusion, myocardial oxygen supply should be carefully balanced with myocardial oxygen demand. Any imbalance between myocardial oxygen supply or myocardial oxygen demand can lead to ischemic events and heart failure. Speaking of myocardial oxygen supply, the right coronary artery, the left anterior descending left circumflex artery maintains perfusion to the heart and controls the myocardial oxygen supply. So any obstruction or narrowing of the coronary artery can decrease the blood flow to the heart, can decrease the perfusion to the heart, and this can lead to ischemic episodes and myocardial infarction, which can in turn lead to heart failure. Therefore, pharmacologic agents that act as coronary dilators dilate the coronary blood vessels, improve the blood supply to the heart, and prevents the incidence of ischemic episodes and heart failure. So coming to myocardial oxygen demand, a common finding in heart failure is increased cardiac workload. Cardiac workload includes preload and afterload. As we can see in this figure, the forces acting on the venous side of the circulation affect myocardial wall tension and contributes to preload. The forces acting on the arterial side of the circulation also affects the ventricular wall stress, and this contributes to afterload. So venous tone determines the capacitance of the veins, and constriction of the peripheral veins increases the peripheral venous volume, which in turn increases the venous return to the heart. So when the venous return to the heart increases, the end diastolic volume increases, and when the end diastolic volume increases, the end diastolic pressure increases, and this causes stretch of the myocardial fibers and increasing the workload on the heart, and this is known as preload. So elevated preload occurs when the end diastolic volume increases. Greater the end diastolic volume, greater the end diastolic pressure, the greater is the preload. The preload is elevated, and this increases the workload on the heart. According to Frank-Starling law, greater the end diastolic fiber length of the myocardium, greater is the force of contraction. So when the stretch of the myocardial fiber occurs, the length of the myocardial fiber increases, and this causes increased force of contraction. The heart contracts with a greater force, and this increases the workload on the heart. This increases the cardiac workload and contributes to preload. So end diastolic volume is equivalent to preload. Greater the end diastolic volume, greater is the preload. Therefore, pharmacologic agents that act as venodilators, they dilate the veins, and this causes pooling of blood in the peripheral veins. So the venous return to the heart decreases, the end diastolic volume decreases, and this decreases the workload on the heart. So now that we know that elevated preload can lead to heart failure, so let us see what are the factors that are responsible for causing elevation of preload. Administration of blood plasma expanders or sodium retaining agents can expand the blood volume, and this leads to elevation of end diastolic volume and rise in preload. Certain valvular diseases can also lead to heart failure. For example, malfunctioning of the aortic valve can cause regurgitation of blood from the aorta to the left ventricle, and this increases the volume of blood in the ventricle that must be pumped out. So this increases the workload on the heart, leading to heart failure. Also, due to malfunctioning of the mitral valve, there is retrograde ejection of blood from the left ventricle to the left atrium, resulting in a decline in cardiac output. Next, in patients with systolic heart failure, because of hypofunctioning of the left ventricle, because of poor functioning of the left ventricle, the ventricular volume of blood is ejected less efficiently. So the volume of blood that is retained in the ventricle is high, is more, and this increases the workload on the heart, this increases the strain on the heart, and also decreases the cardiac output, thereby leading to the development of heart failure. Next, in heart failure with preserved ejection fraction, where there is stiffening of the left ventricle, there is loss of elasticity of the ventricular wall, and this reduces the compliance of the ventricle. So there is impaired ventricular filling, and a small increase in the end diastolic volume can cause a high rise in end diastolic pressure, and this can increase the cardiac workload and place strain on the heart and lead to the progression of heart failure, lead to worsening of heart failure. So this is how the venous tone regulates the end diastolic volume, and when the end diastolic volume increases, the preload increases, the cardiac workload increases, and this leads to worsening of heart failure. Talking of afterload, the forces acting on the arterial side of the circulation contribute to afterload. The tone of the systemic arterioles determines systemic vascular resistance. When the systemic vascular resistance increases, the arterial impedance increases, so the ventricle has to pump forcefully to overcome the resistance in the arteries, and this places strain on the heart, this increases the workload on the heart, and the afterload increases. So afterload is the tension that develops in the ventricular wall during contraction. So afterload is affected by systemic vascular resistance and arterial impedance. So when the arterial impedance increases, for example in conditions such as hypertension, atherosclerotic diseases, or narrow aortic opening, these conditions increase the arterial impedance, and the ventricular force of contraction increases to overcome the impedance, to overcome the resistance, and this increases the workload on the heart, this increases the afterload, thereby leading to progression of heart failure. Therefore, pharmacologic agents that act as arterial dilators dilate the blood vessels, reduce the systemic vascular resistance, improve the cardiac output, reduce the strain, reduce the cardiac workload on the heart, and thereby help in the management of heart failure. So to sum up the key points, the tone of the coronary blood vessels controls the myocardial oxygen supply. So coronary artery dilators help to maintain perfusion to the heart and prevents the development of ischemic events and heart failure. The tone of the venous blood vessels contribute to preload. So vasodilators decrease the end diastolic volume, decrease the preload and the workload on the heart, and prevent the development of heart failure. Thirdly, the tone in the systemic arterioles contribute to systemic vascular resistance, which in turn leads to increase in afterload. So increased systemic vascular resistance increases the afterload and the workload on the heart. Therefore, arterial dilators are very useful in the management of heart failure.